Shall we, ma'am? Hello. Trustee and former Chairman Charotar Arogya Mandal Dr. Bhikhabhai Patel. Our today's chief guest, former Secretary Ministry of Health, Government of India, Ms. K. Sujatha Rao. Honorary Secretary Charotar Arogya Mandal Jagrat Bhai Bhatt. Invited guests, my colleagues and dear friends and students. Good morning, everyone. It gives me great pleasure to welcome you all to the 16th H.M. Patel Memorial Lecture being held under the auspices of H.M. Patel Program for Academic Excellence. Charotar Arogya Mandal has instituted the Memorial Lecture Series as a tribute to its founder chairman late Dr. H.M. Patel, whose death anniversary is being observed today. This lecture series is an attempt to provide a platform to raise issues of concern in the domain of public health. This year, for the first time, we have made arrangements for telecasting this lecture live, and we are indeed very happy that several institutions like Indian Institute of Public Health Gandhinagar, Institute of Rural Management Anand, Indian Institute of Health Management and Research Jaipur, Dhan Foundation Madurai, and many individuals are with us on this occasion as well in this live feast. I welcome you all on this occasion. The lecture series has benefited from the experiences and views of many such eminent speakers like Dr. Jay Prakash Narayan, Dr. Abhay Mang, Dr. John Oman, Dr. Yogesh Jain, Dr. T. Udwadia, Dr. Farooq Udwadia, Dr. M. R. Rajgopal, Dr. Sudarshana Iyengar, and the late Mr. Keshav Desiraj. We are privileged to have today Ms. K. Sujatha Rao, former Secretary, Ministry of Health, Government of India, as our chief guest. We begin today's program with a prayer with which we begin our day, every day, which is rendered by Dr. Bhalendu Vaishnav, head of our Department of Medicine. I request him to offer a prayer.
ॐ तत्सत् श्री नारायण तू पुरुषोत्तम गुरु तू सिद्ध बुद्ध तू स्कंद विनायक सविता पावक तू ब्रह्म मजद तू यहव शक्ति तू ईसु पिता प्रभु तू रुद्र विष्णु तू राम कृष्ण तू रहीमताओ तू वासुदेव गौ विश्वरूप तू चिदानंद हरि तू अद्वितीय तू अकाल निर्भय आत्मलिंग शिव तू ओम तत्सत् श्री नारायण तू पुरुषोत्तम गुरु तू.
We observe today 28th death anniversary of our founder chairman Dr. H.M. Patel. May I request the dignitaries on the dais to light the lamp and offer floral tribute to our founder chairman. I now request our Dean, Pravusha Medical College, Dr. Himanshu Bhai Pandya, to felicitate our chief guest, Ms. Rao, and offer a bouquet. Dr. Harihara Prakash, Principal, College of Physiotherapy, would felicitate our trustee and former chairman, Auditorium Patel. Raksha Parmar, Principal, Nursing College, would felicitate our secretary, Govt. Bhai. May I now request Dr. Amrita Ben to introduce our chief guest and share her thoughts.
Samraj. Our chief guest, Ms. Sujatha Rao, Jagrat Bhai, Utpala Ben, faculty and students, invited guests, ladies and gentlemen. Sorry, thank you. It gives me great pleasure to welcome you to the 16th H.M. Patel Memorial Lecture being held today. I welcome you on behalf of the chairman, Shri Atul Bhai, who greatly regrets he is unable to be present here today. This lecture, as you have been told, every year pays tribute to the founder chairman of the Auditorium Arogya Mandal on his death anniversary. As Utpala Ben mentioned, I believe we have benefited immensely from the Memorial Lecture Series, with views and thoughts of eminent experts in the field of public health. And I do believe that these lectures have, over the years, helped us shape our own thinking on how we should work. And I would also like to believe that there is some contribution that we have been able to make over the years in a small way in influencing the minds of those who are in the business of making policies related to health. I know how important this was for the founder chairman and how glad he would be to see the initiatives being taken had he been alive. We are indeed extremely fortunate to have with us Ms. Sujatha Rao, an outstanding civil servant who spent 20 years of her 36-year career in the health sector at state and federal levels before being appointed Secretary in the Ministry of Health and Family Welfare, Government of India, in 2010. An MA from Delhi University and an MPA from Harvard University, which she attended in 91-92. Ms. Rao was a Takemi Fellow, pardon me if I pronounced it wrong, at the Harvard School of Public Health in 2001-2, and Gro Harlem Brundtland Senior Leadership Fellow at the Harvard School of Public Health in 2012. As Health Secretary, she was involved in the first ever national program for non-communicable diseases, the process for a national policy for use of antibiotics, and introducing vaccines in public health. Previously, she was Director General of NACO from 2006 to 2009, when she was instrumental in establishing systems and building up NACO with a capacity to implement programs with a 5-fold budget increase. She has represented India on the boards of the WHO, the Global Fund for HIV, AIDS, TB and Malaria, and UNAIDS. She was a member of the 6-member Global Advisory Panel of the Bill and Melinda Gates Foundation, founding member of the Public Health Foundation of India, member of the Advisory Board of the Ministerial Leadership Program of the Harvard School of Public Health, member of the High-Level Panel on Global Risk Framework of the National Academy of Sciences USA, and trustee of the Population Council USA, among other positions. Ms. Rao is also a writer. Her book, brought out in 2016 by Oxford University Press, is titled, "Do We Care? India's Health System." Currently, Ms. Rao is member of the NHSRC, Government of India, and member on the boards of a number of NGOs. Importantly, among other commitments, she is also Commissioner of the Lancet Citizens Commission on Reimagining India's Health System, centered around introducing universal health coverage. Given all that we have gone through over the last year and a half, Ms. Rao could not have chosen a more appropriate topic for today's memorial lecture. Post-COVID India, changes required in our healthcare delivery system. The second surge of COVID-19 especially has exposed many deficiencies in the healthcare infrastructure and systems across the country. We were witness to the severe shortage of beds and oxygen, trained manpower, and equipment. With her considerable knowledge and perspective of India's health system, Ms. Rao is uniquely placed to talk with authority about what we need to do to prepare ourselves to not only cope with the present situation, but also future epidemics that we seem destined to live with in the future. While we look forward to listening to Ms. Rao's thoughts, I would like to take this opportunity to say how very proud I am, and I'm sure it is a feeling many from this area and indeed beyond would share, of the dedicated work the doctors, nurses, and staff of this institution have done to provide thousands of COVID patients the care and comfort at a time when it was most needed by the community. As the only hospital between Ahmedabad and Vadodara that is capable and equipped to treat critical care patients in large numbers, not only were the doors of the hospital kept open all through the lockdown, but even at the peak of the crisis, when most hospitals were denying admissions, and there was severe shortage of oxygen and medicines. No patient was denied treatment. I understand that at one point of time there were over 600 patients, most of whom were critical and on oxygen, in the hospital. And as patients still kept pouring in, the trauma and emergency area became a 30-bed ICU. And when even that proved inadequate, a parking lot was converted into a 50-bed field hospital, set up in a matter of 2 to 3 days, manned by volunteer staff and students. All this requires foresight to plan facilities and services that can meet a disaster such as this effectively. But more importantly, it requires character, dedication and commitment, and perhaps most critical, courage. To do what the doctors, nurses, and other staff did, they deserve all our deepest appreciation and gratitude. Let us give them a hand. But I also believe that as a healthcare institution that has always sought to become an example of the profession of medicine, we had no alternative but to do what we did. This was an opportunity to demonstrate to the world the true meaning of medicine, service and sacrifice. That we were able to use the opportunity and in the process became an example of what the profession stands for is a true reflection of this institution's character and strengthens its vision to provide solace to the suffering, the vision of the founder chairman provided for it. May I thank you all for your presence and thank Ms. Rao once again for being with us today. I now invite her to deliver the H.M. Patel Memorial Lecture, but I would also request her to agree to take questions at the end of the lecture. Thank you.
Dr. Patel, Dr. Bhatt, I must pronounce your name properly, so Dr. Distinguished guests and friends. It is indeed a pleasure to be here and a great honor to be delivering the 16th H.M. Patel Memorial Lecture. I have heard a lot about the great work being done by Bhikhabhai University and its various institutions in delivering excellence in healthcare. I have for long wanted to visit this place. I'm glad that I finally made it. There are lots of colleagues who used to keep telling me about this college, and I missed a lot of several opportunities that I had, but I think, somewhere timing is something that somebody else chooses, and when the time comes to visit, you do so. And I think that's what happened this time. Having spent more than 2 decades in the health sector, nothing gives me greater pleasure and satisfaction than seeing such an unswerving commitment to excellence in healthcare provided with compassion and empathy. That's important because there are several institutions providing excellence, but I'm not so sure they give the similar and equal emphasis to the values of heart, compassion and empathy. I do feel privileged, therefore, to be here today, and I thank you for inviting me. And more than anything else, to be here on Dr. Patel's Memorial Day. He is a senior civil servant, and I feel and I hope that we are all living up to the high standards and traditions that he left behind. They were really, really great civil servants, and we've always been inspired by stories that we'd hear about people like him. We are meeting today under the cloud of a virus that has caused havoc and disrupted our lives. The COVID-19 pandemic is one of the most impactful health disasters in terms of spread, virulence, and case fatality, second only to the 1918 Spanish flu. While 180 lakh people are estimated to have died in the flu pandemic, we have clocked in about 50 lakh deaths now, and the pandemic is yet to end. In India, we are currently reporting 5 lakh deaths, though experts have estimated to be undercount by 6 times. Such undercounting could, however, be due to misclassification, misdiagnosis, or deliberate misreporting. Many deaths could also have been of non-COVID patients who could not get timely treatment, as all hospitals are focusing on COVID patients. So this is one area of research I would commend your college, for example, to take up, because it is important to know the causes of death, when did they die even after turning negative, but essentially due to the COVID conditions. This is all extremely critical information, and research must be done irrespective of the political consequences it may have or any other consequences it may have, because truth we must know about this virus. Reliable data is a very critical aspect of pandemic management. Basic epidemiological and clinical information of where, when, age, gender, nature, or severity of pre- and post-COVID morbidity and mortality should be available on real-time basis. Since data during pandemic times is available at different data points, public health agencies doing surveillance, for example, ICMR and NCDC were carrying out sero-surveillance studies. Public and private hospitals were treating patients, and pharmacies were dispensing medicines So, if you were to even track the pharmaceutical, the sales of antibiotics for treating pneumonia or lung diseases or whatever in the pharmacy shops, you would have got a clue as to how many people are facing from respiratory infections. Ministries at central and state levels that were collecting program data, and research agencies like DBT and vaccine and drug manufacturing industry. So these are all the agencies that have the data of what happened in and what was happening during as the COVID-19 pandemic was unfolding. It is necessary that therefore a central agency is established most immediately to collect and collect such data. We don't have one, we didn't have one. And that is the reason why even today as I speak to you, data is fragmented and we don't have the whole picture. The story can only be told when you know all the nuggets and put them all together to make the story. Not just only take how many people have survived COVID, how many are positive, and what is the positivity rate. That's a very, very superficial set of data to monitor. So it is when this is collated and there is an institution that is getting all this data from these various agencies that the full import of what COVID has done to us and is going to do in future will be clear, and that's when policies need to be tailored. Because policy changes in pandemic management need to be nimble and very quick in keeping with the constant shifting scenario, more so when there is incomplete information about the virus, as we saw this time. This is necessary in order to ensure that policy is ahead and not reactive to unfolding events. The COVID pandemic brought out clearly the need to develop expertise in the country for taking up such data analytics. I mean, what was the ministry depending on? Boston Consulting Company and KPMG. Are they? They are an accounting firm. They are consulting firms. Do they know enough about data analytics? See the complexity of data in a pandemic like this, and we didn't have, or at least the ministry didn't feel they had the expertise to collect the data, and they depended on these firms. In a post-COVID scenario, this needs to be given a high priority, therefore, and ensure the availability of relevant skill sets. Epidemiologists, biostatisticians, virologists, relevant clinical experts at all levels of governance, not just at the center, but at the state and district levels and in teaching institutions. It is the lack of such expertise that is the main reason why infectious disease control program did not really take off. It was a World Bank program established in the NCDC, and for example, even after maybe 8 years or 10 years of implementing that program, in UP, 75 districts, we still don't have even one epidemiologist in that state. 75 districts, not an epidemiologist. So how do you then contain viral outbreaks? So what we really need are teaching and training programs in our medical colleges and institutions on building a culture of evidence and data analysis. Such a culture is equally important for clinical doctors for ensuring better patient outcomes. Basically, the culture for looking at evidence, culture for looking at data, analyzing it, and then prescribing treatment or policy prescriptions is something that we need to foster and nurture in our country. The second pillar in health delivery in general and pandemic management in particular is communication with people. This is of foundational importance. Be it polio elimination or reducing HIV incidence, communication played a central role in the containment strategy. Some of you will recall the TV ads at prime time on all news channels and media publicity, including energizing our leaders and influencers like movie stars, cricketers and political leaders from panchayat level to the President of India, putting that polio drop in a child on the day when we were to launch the polio campaigns. Likewise, for HIV, substantial funds were spent on intersectoral campaigns to spread awareness about HIV and the use of the condoms as the only prophylaxis, just as a mask is for protection from COVID. Under both these programs, extensive use was also made of civil societies, NGOs, self-help groups, voluntary organizations like Lions and Rotarians. Volunteers provided critical messages and administered the polio drops or spread awareness of HIV at bus stops, train stations, on top of the trains, migrant trains of Bihar, which were so vulnerable to HIV infections, inside the trains and outside the markets and so on. Almost 25% of the HIV budget was spent only on social mobilization and spreading awareness. Such awareness programs in a sustained manner are essential for bringing about behavior change. So the less than 40% in 2006 were using condom, and by the time I left, it was almost crossed 92%. And the more important indicator is people going to the market and buying the condom, not just government distribution, but when you buy and spend money, that means you have got the behavior change for safe sex practices, which was so critical for us to have contained the HIV epidemic, since that was the only way in which you could protect yourself. So for containing the spread of COVID infections, after some initial confusion, it was clear that there were only two options: using a mask and maintaining distance by avoiding crowds. However, as we can see even today, we are having problems of getting people to comply with these two behaviors. Non-compliance and indiscipline among people to adhere to these basic precautions is a reason for governments to frequently resort to lockdowns that have had such a devastating implication for our daily lives. I'm one of those, maybe in a minority right now, but I'm convinced that lockdowns is not a good public health measure. It is not recognized as a public health tool to contain disease. We must remember, COVID has not gone and it will not go. Now another new variant has come. After this is over and it becomes maybe an epidemic and it gets localized, believe me, after a few years you'll have another form of viral outbreaks. Just think, from 2003, we have had SARS, we have had H1N1, we have had H5N1, we have had how many? Zika, Nipah. I mean, you can just list out at least 7, 8 viral outbreaks here or there constantly happening. So there's something happening out there, and we just have to learn to live with the virus and, change our behavior to keep ourselves safe, not by locking ourselves up in our homes. So the second most important aspect while rebuilding our health systems is to build a strong culture for public communication and grievance redressal. When public are informed and the grievance is heard, half the battle is won, as it is lack of information or inability to access redressal that induce fear, panic, stigma, and irrational behavior, as we saw in great abundance in several instances when patients went around buying useless drugs at exorbitant amounts, or the manner in which we treated those working with COVID patients, or the way in which we disposed of dead bodies that were infected with COVID. You will all recall, and I don't think I have to underscore the importance of what this fear and panic and stigma did to people we love, people we know, and the kind of panic it created in society, only because people were so confused. So we are spending too little on communication, and that's where we need to reverse that particular aspect. A third most critical gap that needs to be addressed post-COVID is building a public health infrastructure. Diagnostic laboratories, hospitals, emergency services, trained personnel, and mortuary services, and so on. Due to the decades of neglecting the health sector, we still have half the beds required and much fewer doctors than the norm. WHO's norm is 1 bed and 1 doctor per 1,000 population. Against that, we have 0.5 per 1,000 population beds and 1 doctor for 1,500 population. Now, this is a national average. In some state like Bihar, it will be 1 doctor for more than 3,000 population. A closer look will show how uneven and skewed it is in favor of urban areas and in more developed parts of the country. Large swaths of the country, particularly in the north, are bereft of hospitals and doctors, both public and private. You have to only go to eastern UP and large parts of Bihar, and you'll find there's no private sector there, there's no public sector there, there's no doctor, and there's absolutely empty. I mean, in Gorakhpur, when you find 200 children dying of JE and so on, it is almost because for 200 miles around Gorakhpur district hospital, there's nothing. It's a blank check, nothing. So people with even little symptoms of diarrhea, if they want any critical care, they have to travel 200 miles to reach the Gorakhpur district hospital. So that is the kind of crisis of infrastructure in our country, and the spread out. So that is largely because of the acute underfunding that we've had all these years. Because resources are finite. Public spending in India has never been more than 1.15% of GDP on health. Over 60% of health spending continues to be by households. On account of such low spending, the public health infrastructure has been very weak. We all witnessed the inadequacies in the health infrastructure that delayed the scaling up of testing, and later, under wave 2, loss of lives for just an oxygen or a bed. Those were nightmarish months for me, because people would ring me up, and I worked 15 years in the Ministry of Health, right from director right up to the secretary post, and I couldn't get a bed for a friend. I mean, you could imagine how it broke my heart. But that, even Dr. Guleria would say, ask me anything but not a bed. So that was the kind of situation in Delhi, and one just couldn't help it. But now things are much, much better, and I'm sure we will never see those days again. We witnessed how many states had to struggle to get adequate number of laboratories with capability to undertake RT-PCR tests, and in several instances, patients struggled to get oxygen-supported beds and admission to ICUs. Even at the community level, states had to struggle to get isolation beds and quarantine facilities set up at the community levels to reduce crowding in city hospitals. Human personnel shortage, including shortages in protective gear like PPE kits, gloves, were also experienced in the initial phases. Poorly equipped public hospitals at the district and regional levels resulted in the bunching of patients in cities and private hospitals, adding to the already stressed out hospital budgets, household budgets. Failure to have a policy underwriting such expenditures led to massive spending on treatment that is estimated to have been 65,000 crores in a short gap of 1 year or less. We have spent about 65,000 crores of out-of-pocket expenditure on just treatment. That's one estimate, and that's a huge number. Some states like AP, however, did extend financial security, providing all those, whether rich or poor. It was a policy, a state policy, that they will all be provided free treatment. But in a state like Telangana, the private hospitals really exploited patients with package rates. So supposing you wanted an RT-PCR test in a hospital, it was not, you could not just take that test and pay that 4,000 rupees which ICMR had fixed. You had to take a whole package of 10,000 rupees, of which RT-PCR test would be one of them. So, now if you're 3 of you in the family going, 30,000 rupees you spend on just one test. And that's not a permanent test either. You might need it again the following month. So that is how they made money. And extended ICU stays and unnecessary tests. Overall, the private and pharma companies are reported to have a CAGR of almost 22%, while the rest of the economy tanked. Your normal average CAGR has been, as far as I know, about 15%. During this year, they made 22%, which is not surprising to note with household expenditures so high. But while the rest of the economy tanked, this sector did flourish. The fact that most states were able to quickly gear up the infrastructure is indeed a tribute to the state leadership. For example, states like Karnataka and TN had just one RT-PCR testing laboratory in April 2020. Within 6 to 8 months, they were able to put up 104 and 146 laboratories respectively. Likewise, Kerala and Karnataka conducted serosurveillance and fever surveys. They set up 24/7 state-of-the-art control room with facilities for virtual training and video conferencing, GIS mapping of cases and contacts, heat mapping technologies for containment zones and clusters, and large data management of contact tracing and quarantine. Real-time tracking of ambulance services and dissemination of IC with daily media bulletins. A tele-ICU program with support from intensivists working in the private hospitals to train and guide the ICU staff working in different medical colleges and district hospitals, and so on. So there was this huge innovation. That's a good thing that we saw in COVID, was a massive innovation that some of the states exhibited in trying to get a hang on how to manage the pandemic through use of technology, through use of systems, and through use of public and private sectors working together shoulder to shoulder. That was a very, very heartening example to see. So both these states also decentralized state efforts by engaging the panchayats in a very intensive manner. Karnataka was also a pioneer in capping the price of tests, which later on other states took up. and tracking drug sales by pharmacy stores to patients suffering from severe respiratory infections and lung infections. A common thread in all the well-performing states was that they followed the public health approaches of testing, tracing, containing, and treating. They decentralized the implementation and closely monitored data. Recently, the Niti Aayog published an excellent study providing data on the infrastructure gaps in the 701 district hospitals under 10 key indicators and ranked states under each of them. Data shows huge gaps that must be bridged expeditiously. Action to do so has actually now begun with the 1.5 billion US dollars loan that we're taking from the World Bank, and I think another $500 million from the ADB. I think the Prime Minister launched this about a month ago, this program in Varanasi. The focus is to both ramp up the primary health wellness clinics as well as strengthen district hospitals with ICU and oxygen supported beds, including district level laboratories, a chain of district level laboratories. Such expansion of access to emergency care and hospital beds is badly needed and long overdue. You know, there are district hospitals in UP and Bihar and Madhya Pradesh. My goodness, you will be so stunned to see them. I think sometime you must organize a Bharat Darshan to know another part of the country and not just think this is what India is. And you will see, I don't even want to begin to describe what they're like. So, you know, they needed investment, and I'm really so delighted that some effort is going to be made to ramp up our district hospitals. Gujarat can benefit a great deal with this scheme. As per the Niti Aayog survey, the position of Gujarat's district hospitals on the 10 critical indicators is not very encouraging. You have, I think, about 22 district hospitals, and if you go through each of the 10 indicators, not more than 3 or 4 come up to some standards under one or the other indicator. For example, functional beds per lakh population, you have 19% of the hospitals have. Ratio of doctors, nurses, and paramedics, only one hospital of the 22 hospitals reach the standard. Proportion of support services, 14 support services are supposed to be there in every district hospital. Only 3 in Gujarat have. Proportion of core health services, that means at least 14 specialists must be there for providing the core health services in a district hospitals. And in Gujarat, only 5 hospitals have the whole complement of 14 specialists. Proportion of diagnostic services, at least for 14 set of conditions you must be able to offer diagnostic services, only 2 hospitals in Gujarat offer it. Bed occupancy rate, only 4 hospitals have something of full occupancy, the rest of them are about half, 48%. C-section rate, 17.5%. Surgical productivity index, per surgeon, what is the productivity ratio? It's 300, which is half of Delhi's 600 per doctor. So, in every indicator, OPD per doctor, only 6 district hospitals see at least 38 doctors in patients per doctor in a hospital. So there is a huge lag between what could be a norm and what is in reality. That means even in one of the richest states of the country, that's Gujarat, which has 4 times more income than Bihar, the status of district hospitals is wanting, means the lag is the whole country as a whole. I mean, it's not Gujarat is only one of the states. Is that a huge amount of investment really and attention needs to be paid to ramping up district hospitals and not only depend on private hospitals and privatization to bridge this gap. So the Niti Aayog study of district hospitals gives the governments an opportunity to do evidence-based investment planning. So instead of distributing resources equally or on a per capita population basis, they need to spend the money for fulfilling gaps. In such an approach, the weaker and the poorer states and districts will get differentially more resources. Such districts and states are also more deserving, as the people in such areas are not only typically poorer but also do not have the option of resorting to the private sector. Poor districts and states, due to high levels of poverty, do not have the required paying capacities to sustain the private sector. I mean, if you look at Bihar, 50% of the population is below poverty line. Now, how do they sustain a private hospital paying huge amounts? So it is these different multi-sectoral poverty indicators that you need to take to identify the priority areas where public investment needs to be focused. Even as infrastructure is critical, HR is also an equally critical determinant. It is tempting to resort to the lazy solution of relaxing standards, expanding incentives for further privatization and commercialization of medical and nursing education, and increasing intake of students. But ensuring quality education is tougher and more important though. Moreover, the pandemic has also shown the need to reform and training curricula of medical students so as to improve the skills and competencies of medical graduates on handling emergencies. The pandemic also revealed the woeful status of public health as a discipline and the availability of public health specialists, epidemiologists, biostatisticians, virologists, pathologists, entomologists, microbiologists. Where are they? We need to acknowledge the centrality of public health as a distinct discipline from clinical and medical knowledge. Like any other, here too, public health expertise develops with years of researching and working in the field of public health. I say this as unlike Western countries, in India anyone and everyone speaks and gives opinions on public health matters that often confuse the people, particularly due to TV channels that tend to substitute public health experts with clinicians who may not have the full understanding. Due to non-availability of reliable source of information, people tended to rely on TV interviews to take their decisions. The mad scramble for remdesivir or CT scans for diagnosis, or the irrational fear of a third wave affecting children more disproportionately resulting in the prolonging of closure of schools are examples of such a situation. Finally, the enormity and overwhelming extent of the pandemic did disrupt the routine care of non-COVID patients. Maternal health, TB, HIV, accessing hospitals for chemotherapy or dialysis were badly affected, entailing serious adverse consequences. Since it is clear that the virus is not going away anywhere, we need to learn to live with it and develop plans and strategies for coping with such eventualities so the functioning of the whole health system is not stalled indefinitely. And this is where I would commend you on your 150 villages program, where you're developing the parallel expertise and competencies and delivery systems so that if such an eventuality comes, the whole centrality of thinking is focused on trying to address the demands of here and now. At least the chronic patients don't suffer for want of drugs and immediate treatment if they needed it. So I think we need to work on such strategies. Ensuring equitable access to basic emergency care by bridging the wide interstate and interdistrict variations in infrastructure capacity, preparing detailed district-level emergency plans to ensure quick responses by locating not only appropriate infrastructure but also the appropriately trained human resources, building safety valves to ensure that non-COVID patients are not neglected for undefined lengths of time are of prime importance. Such a responsive health system can, however, be possible only when the foundation of the health system is a family-centered primary healthcare system. We need to rework the current primary healthcare model to make it not facility but community-based, held accountable to the communities. Such micro-level planning will also require mapping out private sector facilities and ensuring their readiness at times of need. This requires bold policies and imagination. What do I mean? Family-based and community-centered accountable primary healthcare systems have been an aspiration for years. Currently, we have a primary health and wellness clinics that treat patients seeking treatment. Focus accordingly in all these years has been in making people develop health-seeking behaviors. Come to the facility, there's a doctor here, there's a lab attendant here, there's a nurse here. Come to the facility, don't go to the quack. Come here and we will give you medicines and we will take your tests and we will treat you. That has been the health-seeking behavior, a strategy that was followed in Kerala in the 50s and 60s. And that's why the indicators of maternal health are so good, is largely because the gynecologists were on the road telling every woman, come to the hospital for delivery. So the institutional deliveries were 99% for many years ago, and therefore the maternal mortality was reduced. But such health-seeking behavior does have its own consequences and costs. But this has not worked out in the primary health care space. 7 decades of working on this model has shown its inadequacies. It is therefore time to ensure that we change the system. We need to have at least say 3 doctors in a primary healthcare center set up for 30,000 population or 6,000 families, with each responsible for, one doctor being responsible for 2,000 families. This would entail having every family and individual in the family registered and with the doctor, and a complete idea of the demographic and health status of the people under his charge. In other words, there's a PHC. Today what do we have? We have a PHC for 30,000 population. We have put 2 doctors there. And the patients come to the facility, so they are treated and they're gone. That's it. There's no further follow-up. From here they could go to another private doctor, or they could go to a quack. They may not appear again for the next 6 months. When something gets serious, they again come here. There's no referral system either. But what does this mean? Something like what we find in UK, the GP system, where the doctor there is given earmarked 2,000 families with the entire demographic and the health data of those 2,000 families, who he gets to know by name. I mean, transfer policies don't change him for the next 7 to 10 years, so he really literally gets to know each family. So with this, the data, he gets to know how many infants need to be immunized, how many are the old people who are bedridden in his population, how many people require therefore house visits, how many women are in the ANC stage and require checkups, how many are due for the delivery, how many are the TB patients who need to be seen, how many are the diabetics and hypertension patients who are not showing improvement and need much more intensive management. I mean, these are the follow-up. So this is the kind of data that the doctor personally monitors and is accountable for. And there can be incentive systems to be given to say, if in your area of 2,000 population, we find that the diabetic patients have improved over the last 2 years or 3 years, you get a bonus of so much and paid for good patient management. Today we don't have that. We diagnose the diabetic and hypertensive, and you look at the records in the villages if you want to see. Same drug, metformin, will be given for 3 years. The fellow will be at 310 for last 3 years, and there's no change. And it goes on and on and on automatically. Ashas will go and give the drugs, or the A&M will go and give the drugs month to month, and that's it. There's no evaluation. And telemedicine, I have gone through many of these records in Vijayawada, where the telemedicine is being provided services by Apollo. Nothing wrong with Apollo, but the model I'm saying. So every month a new doctor, because the attrition of the doctor at the telemedicine center changes. They pay 80,000 bucks for the specialist, but then he's not interested in having his career as a telemedicine doctor. The minute he gets a job somewhere else, he quits. So every month a new doctor comes, and every month he changes. The new doctor has a different perception of the readings. He changes the medicine, and patient is continuing with the same level of ill health year after year, and there's no evaluation. So this kind of a thing needs to change. It is the doctor, the PHC, who ought to be held accountable for the health and well-being. So let him do cancer screening, let him do whatever screening of those 2,000 families, and see that they all attain the minimum level of health and well-being, and then he should be, of course, rewarded appropriately. So this would then imply that the doctors then work with and lead a team, which is their own BSc nurse, they have their own set of ashas and A&Ms of those villages, and they can get in more village volunteers or whatever it is to manage situations. And also it would imply other policies and incentive structures of the government to incentivize such kind of primary healthcare doctors and personnel. So to sum up, the changes in the health sector post-COVID clearly point towards a need to have a reform agenda for making public health central to our health system, building our capabilities in data analytics and evidence, imparting communication skills among our caregivers, and an ability to work with communities and patients as key stakeholders in the process of achieving good health outcomes, building the infrastructure to standards, and revamping the primary healthcare center to giving primacy to family health approaches rather than program-driven disease control approaches. So this would really imply that over time, each of these doctors gain a degree in family medicine, gain a degree in public health, and that's how the whole environment for family medicine, public health comes from bottom up, and build a culture of family-oriented, community-based primary healthcare system, which becomes the bedrock for further management of patients and illness and of course referral to the higher centers of care. So the pandemic was devastating, not just in terms of lives lost, but the disruptions by way of loss of incomes and life balance. Children have suffered the most. India will never get such an opportunity to focus on health reform. We need to take advantage of the moment and see that India quickly develops a good health system that is accessible, affordable and equitable, with capacity to provide the services required by the people. And it is in such a context, I'm so delighted to be here. I've heard great things about your institution, and I think the focus, what has charmed me most, is that you focus on values, you're focusing on compassion, health, and the bridge that divides the urban and the rural by having extensive village-based programs. I've seen such a approach to medical education only in CMC Vellore, which I repeatedly used to get very inspired by that model. And it was when I was member secretary to the National Commission for Macroeconomics and Health, that was one of our primary recommendations, to say every medical college must adopt 3 blocks. That means 3 CHCs and PHCs and the sub-centers and those villages, and the budget that we are spending should be given to the medical college so that the students go in rotation to man those centers, work. I mean, and as an IAS officer, I had to stay 1 week in the village. That's how my training started, with the patwari, as you call them. I think they call them patwari here also, the village servant, and go with him every day carrying those books and measuring the fields. But you know, I never did it again after that. But then I know when somebody comes to me and says this land has been knocked by somebody else, I know what it means. Then 2 weeks as a revenue inspector, then a month with the tahsildar, and up the lot, you know. So in Thailand, for example, the Surgeon General there, or the Director General of Health Services, would have worked for 3 years mandatorily in the district hospital. That is his first posting when he enters the government. So he knows what it means when you talk about TB and malaria and what does district hospitals need. What is our Director General of Health Services? He has spent all his life in RML or Safdarjung Hospital inside the operation theatre. And he comes out and he becomes the Director General. He has never seen a sub-center. He's never seen a PHC. He doesn't know what TB means. And he's expected to give the technical advice to the ministry. And that is a very tragic development that has happened, because over the years we've neglected the technical arm of the ministry. We've had very, very eminent directors of general or health services in the past, and today we don't have any. So the space is being occupied, unfortunately, though as an IAS officer, but having spent so many years in the health sector, I'm painfully aware of my own limitations. You know, you can never substitute what is a core technical expertise, and so this kind of reform, of course, needs to be taken. And COVID has taught us a lot, and I think the best in your institute and in the country as a whole, we ought to really look at the COVID data very clearly, openly, write articles about it, let people know, so that there's a much more exchange of information, and sometime in the future we figure out what really happened, so that we know and are aware of COVID-like pandemics in the future, and that we are better prepared and forewarned. Thank you very much for your attention. Thanks again for having invited me. It's been a great pleasure to be here, and I wish you all the very best in your future endeavors.
Thank you, madam, for your truly memorable lecture in the series of memorial lecture. You already summed up, so I am not repeating, but there was learning for all of us present here, including administrators, policy makers, public health experts, healthcare givers of all cadres, and of course students. We will definitely remember the importance of expertise in data analysis and the culture for looking at the evidence in our future planning. May I now request Jagrut Bhai to propose vote of thanks. Sorry, I'm sorry. So, it's open to question answer session. Can we have questions from the audience?
Uh, Thank you, madam, for complimenting us for the model that we are trying to, develop as far as the um, extension and outreach program that we are trying to build. You rightly mentioned that this is indeed a great opportunity, and you mentioned a lot of changes that are required in healthcare delivery system. I am a person from medical education, and whereas all these system changes are required in health systems, I see an equal opportunity in medical education system to change. And it is said that medical education system of a country is as good as its health system, right? And whereas the goal of Indian medical graduate is to develop as a doctor of the primary contact, our regulatory model, including minimum standard requirement, looks at what is happening in tertiary care hospital. What are the number of beds? What are the occupancies? It doesn't look at what model that the medical college has created and how its consultants and its students are getting the benefit of that system, right? Um, so that is because we still are looking at inputs. We are not looking at processes. We are not looking at outcomes, right? So whereas regulatory framework has changed from professional to largely professional public framework, but our regulatory model, if you look at NMC minimum standard requirements, they appear to be same as that of erstwhile Medical Council of India. So I think this is something that this country needs to look at.
You know, you're extremely correct. I mean, you're totally right in what you're saying, and what really amazes me and surprises me is that we are not learning and we are not moving ahead. I mean, you know, the crisis of having a doctor in India, an Indian doctor who has enough skills and competencies to address the needs of the people was something that was articulated by the Mudaliar Committee report in 1959. I mean, it was an indictment of the medical education pattern that we had in 1959, saying that these doctors that you're producing are no good for our rural areas. So what was he trying to say then, and what was the principle behind is that you produce doctors to address a certain need, a certain epidemiological situation in the country. So that linkage, I mean, I tried my best for the years that I was looking at medical education, but the MCI would not look at, is, for example, if you know, Tata Memorial Hospital has huge patient load. How many are the seats they give for radiologists? Two seats, MD. That was, you know, 2009. They've increased now, I think. So, and you know very well what a huge shortage we have of radiologists vis-a-vis the galloping cancer in our country. Pediatricians, gynecologists, take specialty by specialty wise, they don't give the MD seats in accordance with the what is the demand in the market. So that linkage between the needs, I would say, or the disease pattern in the country and the specialities that we need to produce in the country, the specialists and specialities we need to, there is no linkage. So it's a very arbitrary, you know, you as a promoter come and say, I want 2 seats in some discipline, you get it. And it has nothing, of course there's an overall shortage of all specialities. I'm not saying there is one extra and there's much lesser, but the linkage should be there. And in UK, for example, it is the BMC is completely autonomous and independent, not like our MCI. But there, the UK government gives them an annual demand saying, we want 7 pediatricians, 25 chest physicians, 30 cardiologists, or whatever it is. And it is that demand on which the BMC then works to produce that kind of specialists for the, as dictated by the, not dictated, but indicated by the government. So that linkage is not there in our country. MCI has functioned very autonomously all these years, and they have, so there's a complete mismatch between what we need and what we are producing. So you need public health, family medicine. Now DLB has come out with a beautiful, I mean Dr. Sheth has really done a good job of coming up with an excellent module for family medicine. Are there any takers? No. And can you imagine, even palliative care was recognized, an MD in palliative care as late as 2011. So, the MCI's conservative attitude has been a very, very, stumbling block, if I may say so. And what disappoints me, as you rightly said, there's not much of a change in the new NMC either. In changing curricula, it's very tertiary focused. They're not looking below. And not only that, we have been demanding for a long time that medical doctors must have an exposure to health economics. See, today life has become much, much more complex than than just merely looking at the pulse of a patient and giving him some drugs, right? So health economics, sociology, gender issues have become very important. All these different, anthropology, I mean, these kind of social disciplines need to be, the medical doctors must be exposed to those disciplines also. And at some point mid-career, must be given a choice and exposure to either going for public health or going for clinical practice. And I think public health needs to be given a much greater focus by government, maybe salaries equivalent to a specialist, so that there is a greater attraction for people to want to become primary healthcare doctors and public health specialists, rather than just only everyone wanting to be a cardiologist. So there's a huge reform agenda, and to add to your woes, the tragedy is that all this is known. Nothing new. All this is known and it's in the books available. If only somebody would look at it and just implement it. Lot of consultations, lot of meetings have taken place. Lot of thinking has gone into this, but somewhere it's not moving, and I really don't know what one can do. Sorry about that. Not a very encouraging reply.
I'm from voluntary sector, and what I see now in COVID-19 situation, if you compare it with what NACO did and State AIDS Control Society, or for pulse polio, the NGOs have played a very, very big role.
Yeah.
I think the COVID-19 has sidelined totally NGOs and their efforts. And this is a very big miss, because unless you go to the community and to the remote areas where you can really educate people, that factor is totally missing. And I don't know how to address this.
Well, now they've recognized the fallacy of their policy, because you heard the health minister calling upon the civil society to help in vaccine hesitancy and to spread more people, because after all, even today, I think we have done a commendable job on the vaccination front, no doubt about it. It's not easy to do more than 1 billion vaccinations, but still, in terms of numbers, only half the population is protected with 2 vaccines. So there's still another half to be done. The vaccines are getting wasted. There's a whole lot of issues connected with reaching the last mile. And they're calling upon civil society, but then the civil society is reduced to pulp with FCRA regulations and this and that, so I don't know. They're all struggling with bank accounts and getting funding and so on. So a much more positive policy, I agree with you. In NACO, we spent 25% of our budget went to the voluntary organizations, So unless and until there's that kind of a step up, voluntary would have also meant trust hospitals like this which are doing extension services in villages. You know, it's not for profit, but you're doing it for social programs. They would have typically been provided funding. So that unless and until that kind of program comes up, and they incentivize volunteer organizations and NGOs, and I think they should, because really is a huge role for the community engagement in not only pandemic, in healthcare delivery itself. I don't think it's possible for government to do it all by themselves. No, it's not at all possible. She's saying that, you know, you did so much to volunteer, and it's a fact that in COVID, that's what. So I said they don't have, and now they're reaching out, but it's a bit late in the day. Because I know in Telangana, I mean, it's amazing how they just refused any civil society participation during the migrant crisis. And then we would collect food and so on. That also, then they said, okay, you can distribute it, but only through the police. What does police have to do? You know, if the migrants until they reached, they won't have a policy. In fact, I was engaged. I raised resources from my civil society, civil service colleagues, and joined another NGO, and we put them all in buses and sent them in some dignity. Others were packed in lorries, and every day, you know, till 2 o'clock in the morning, we would be standing on the highway, stopping these lorries, making them unload the migrants, packed like sardines, and get the money returned to them, because all the hard savings went in paying 3,000, 6,000 rupees for the ride to their home, and engage these buses and put them in a proper bus, gave them meals for that one day that would take them to drop them at the villages. I mean, and the government then came so heavily on us, because not so much on me because they won't dare to, but the point is they should have taken advantage of organizations and said, you handle it, because we can't. So it's a very peculiar situation that's developing across the country in not respecting volunteer organizations and seeing the power of civil society in helping to overcome these kind of contingencies. You know, and the pandemic was a horrific thing, particularly burials. My gosh, the kind of pain that people, you know, we needed to have grievance centers. I mean, people were suffering like anything in Delhi. That's when I think we should have. But anyway, but now I think they're learning. Let's hope that civil society will come back. Gujarat had wonderful capacity for civil society participation and panchayats and all that.
But one more thing that happened in Gujarat, and I think Sandeep Bhai will support me. Another hospital that I'm associated with in Baroda, I find out that the government grants have not come for 2 years because of COVID.
Yeah.
And you know, the voluntary, the trust
They cannot-
hospitals
they
don't
cannot-
have funds
They
to.
cannot pay, yes.
And that is really the difficult part, that
I know.
they were still serving the regular patients, and they can't afford to do that.
No, the
on their
HIV
own.
AIDS patients couldn't get their drugs,
Yes.
and the vulnerable populations were starving. They were really hungry. Then they went and they, fortunately got Global Fund to give $10 million to just for food support. These are things that I do feel, yes, that government should proactively have come up and secured the support of civil society. I couldn't agree with you more. I learnt about the value of civil society in NACO. Honestly, they were tremendous. They were such a strength. So I agree with you fully. Any other questions anyone has on COVID? Yeah.
The lessons of COVID in a post-COVID era, but one is to prepare like another possible epidemic. I mean, how we would do something different or better, or we are more. But lessons of COVID for non-COVID situation. I think all those whose opinion or whose thing matters should rise. Just to give an example, we are putting on the mask right now. But before COVID era also, the intensivist or the surgeon in the operation theatre was putting on. Now, whether his eyes were conveying the empathy or not.
I think
So the lessons of learning through COVID, because for the students who will come after a few years, it will be a story. We may say this was done, this was done, it's a story.
Yes.
So what has to be taken to the very essence or logical small points which should make a difference in the way we create our doctors or all policy. I think if there is a consensus statement or a policy document or multiple levels, multiple strata, I think such a thing is a, collective responsibility which we must.
In fact, I wish the Ministry of Health would hold and encourage state health departments to hold widespread consultations to just try and capture the different experiences that different levels of COVID, and then put that together and analyze it to see what sort of policies we need to craft, and to articulate. So even a small thing like what you were mentioning can become a very important and a critical input. But then, like washing hands, you will say, you will laugh at it, but there was a huge Gates funded project in UP on washing hands, and Atul Gawande, you must have heard of him, a great writer. He was in charge of the project. After implementing it for 4 months, just washing hands by nurses and doctors before seeing a patient in the district hospitals of UP, they got 45% adherence. So, habit changing and using this body language and body contact is a very, very critical element of overall health care, which is so ignored and, not at all, no attention is paid to. And that really becomes central in pandemics. For example, you were witness to what amount of stigma and fear people were stricken with. And that should not have been the case. In no pandemic must it be there. HIV, we face the same thing. People would leave HIV patients outside the village and treat him and throw the food as if he was an animal, Outside the village he would be put and given food. Then again we had to have a huge Be Bold campaign, for example, to get the gynecologists to wear masks. And the gynecologist would argue with me, we have done deliveries for 30 years without a glove. Why do we need it now? That was, old practices have to go. Making them wear the overalls and then deliver in the hospitals, HIV patient, took us a huge amount of effort. Now all these are experiences that India has, and we know what stigma, what fear, what discrimination does in contacting both by the healthcare provider and the patient. And all this body of experience I felt could have been used in dealing with COVID, but that was not to be. But I think even now it's not too late, and we need to gather these experiences and stimulate that research. Much more research needs to be done on who died and when they died and why they died. I think it's very, very important, instead of trying to just curb and say nobody died. That's not true. I think that will have a lot of lessons for us on, both clinical and on public health measures. I agree with you that that's something that we should pay attention to. But even then, even if at your college level, why wait for the government? If you could have a seminar with like-minded people from other institutions and just let them be able to relate to how did they cope with it, and then get that. And much more articles need to come out in our journals and all that about the Indian scene, because it really has a lot of value. We're not paying enough attention to research, I feel, because we're so busy with patient care, so those who know don't get time, those who don't know don't get data, and so between the two this is not taking place. But I think somewhere the research is really very critical, and getting so that I'm now stimulated to write a book, Policy Response to COVID Management, trying to capture what happened in at least 4 or 5 states, to see how they crafted policy to manage the pandemic, the good and the bad, to see the weaknesses in the health systems, so that maybe some policy outcomes might come out. But what I mean is more clinical, work, you know. Much more clinical research needs to be done. I really think you people should write and honestly, you mean the education, medical education. I really. They're talking, but why they don't, and they don't have to discover it. All of it is there. I mean, so many meetings have been held on that, you know. I attended too, so you can imagine, and mine is a blip since then. And I was hoping that after they abolished MCI and the new NMC, when Dr. Vinod Paulan were in charge, that something would come out. It obviously nothing much could be changed, and then of course COVID came in. But this is a time when they need to change. You know how ill prepared we were on emergency care, for example. How ill prepared we were. That should not have been. I mean, of course, you know, let us be clear that uh, any pandemic, any health system, no matter how good it is, can only take that much. There will be, if the disease has gone beyond that, you're bound to face problems. That I'm willing to grant. But then, say in UK, there is South UK, there is an institution. When I went to the BMC in a meeting, they told me they just set up a medical college. I think it is south of, where was it? I forget, Aberdeen or something. I don't remember. But the first day the student is made to go to the delivery room and do a delivery. You know, first day of entering the medical college, saying no need to learn anatomy and all. First deliver this kid here. And so, you know, literally shaking. How do you deliver a kid? I'd be petrified to see so much of blood and women wailing and so on. So the changes that they are trying to bring out, I think it would be so wonderful to have some kind of a collaboration to see how is UK, I mean, I'm just taking the name of UK, to see how are they changing their pedagogy and how are they changing their systems. And I think you have enough autonomy to introduce here something like that over here. But I agree with you that NMC has to be much more open and do, but how do I answer for them? I don't know what to say. Thank you so much.
Trustee of Charotar Arogya Mandal, former chairman, and above and all, the mentor of our institute, Dr. Amitaben, distinguished guest, and the person for whom we are looking for, Sujatha ji, our provost, Utpalaben, Shantibai, distinguished guest and family members of Charotar Arogya Mandal. At outset, I thank you very much to Sujatha ji for agreeing us on giving this very wonderful, informative, analytical lecture. Sujatha ji, this day is very important for us because it's in name of our founder chairman, Dr. H.M. Patel. And as Amritaben has said, throughout these lectures, there were all eminent lectures were present in past. And I am very happy that parampara is continued. Thank you very much. In nutshell, I can say she had given a direction. We were working on the issue. We have worked hard on the COVID, but she had given a direction to us, to every department, and inculcated insight for the future. So we are obliged, and thank you very much for coming here and giving us a lecture, a good delivery. I'm also thankful to the print media and electronic media, distinguished guest, and the persons who have joined us on the YouTube. In addition to this, this is the first COVID meeting, first meeting after the COVID. So I should tell our family members that during COVID, the intensivist consultants, upcoming consultants, that's interns, nurse, supporting staff, managerial staff, everybody have done a wonderful, wonderful, wonderful work during the COVID. I am moving in the people, moving with the people, so I know everybody is praising the things. And in nutshell, I can say you all make us feel proud. Thank you very much. Hope this parampara will be continued, and in future together we will able to hear such good, nice, informative lectures. Thank you very much.
Well, this concludes today's program. May I request the audience to please permit the guests on the dais to leave the auditorium. You may follow them. And we have kept hard copy of a lecture outside available, so those who may have, can have it for further reading. Lastly, we will be raising from our seats for national anthem.
गाहे तव जय गाथा।